Да, у меня ничего не поменялось. Угу. То есть я могу говорить уже, да? Beginning lectures, да? Начинаем лекцию. Хорошо, спасибо. Good afternoon, students. Today our lectures about gastroenterology problem. Plan of our lectures. It is first gastroesophageal reflux diseases, chronic gastritis and gastroduodenitis, and peptic ulcer. This diagnosis we discuss in next plan. It is etiology, pathogenesis, clinical symptoms, diagnostic, and treatment and prophylaxis of this diagnosis. Beginning from gastroesophageal reflux. Gastroesophageal reflux, it is signifies the retrograde movement of gastric contents across the lower esophageal sphincter into the esophagus. It may be physiologic, the age of the 1 year due to inadequate development of low esophageal pressure regulation, any verbs dysmotility. It is maybe variance of normal, but gastroesophageal reflux after 1 year, it is pathology. Sphincter must be normal development. Function of the stomach must be normal development after 1 year, and children may be eat without regurgitation. If the gastroesophageal reflux continues, it is may be transformed in gastroesophageal reflux diseases. Gastroesophageal reflux diseases, it is condition in which regurgitation of gastric contents into the esophagus causes clinical symptoms of esophagitis and or leads to the development of complications. Pathogenesis of gastroesophageal reflux disease is next. Factors of protection and factors of aggression may be same to the in this scheme. Factors of protection. It is anti-reflux of the cardiac sphincter, anti-reflux barrier, resistance of the esophageal mucosa, effective clearance of esophagus, evacuation of gastric contents. Factors of aggression. It is hypersecretion of hydrochloric acid into the stomach, chloride acid. It is aggressive impact the lysocene and bile acids. Pancreatic juice in duodenogastric reflux. It is to provocate duodenogastral reflux to gastroesophageal reflux. Some medications, very popular non-steroid anti-inflammatory drugs, it is maybe paracetamol, it may be ibuprofen, to many clinical symptoms, for example, hyperthermia or headache or viral infection, viral respiratory disorders. Mother without doctor's control maybe treat children non-steroid anti-inflammatory drugs. These drugs and corticosteroid anti-inflammatory drugs, corticosteroid, systemic corticosteroid, to maybe provocate gastroesophageal reflux diseases. And some types of food, for example, spicy food, fatty food, too, it is one of the factors of aggression. If the factors of protection low and factors of aggression higher, it is maybe finish gastroesophageal reflux diseases. Very important to different gastroesophageal reflux and gastroesophageal reflux diseases. It is present or absent organic disorders, present or absent inflammatory process in esophagus. If it is only regurgitation without disorders of mucosa or esophagus. It is maybe only gastroesophageal reflux. If the gastroesophageal reflux more than 5 times per day, this pathological regurgitation may be provocate inflammatory process in the abdominal part of esophagus and development gastroesophageal reflux diseases. Clinic of gastroesophageal reflux diseases may be divided in two group symptoms. One, it is symptoms of esophagitis. It is first of all pain, epigastric pain. This pain localization retrosternum. Pain provoked after initiated and maybe severe pain after feeding, fatty feeding, spicy feeding, and sometimes nocturnal pain in horizontal position of the child. Pain may be increase in horizontal position and after physical exertion. And second group symptoms, gastroesophageal reflux disease, it is dyspeptic disorder. Dyspeptic disorder, it is maybe, first of all, heartburn. Heartburn, regurgitation, maybe gaseous eructation, maybe bad smell from mouth, hiccup, maybe nausea, vomiting, dysphagia, anorexia, feeding disturbances. And for gastroesophageal reflux diseases may be extraesophageal symptoms. Extra symptoms, first of all, it is otolaryngological. It is recurrent laryngitis, otitis, pharyngitis. From dental extraesophageal symptoms may be caries, pulpitis, pathology of tooth enamel, bronchopulmonary, recurrent bronchitis, nocturnal cough, and if the severe gastroesophageal reflux may be provoked, attack of bronchial asthma. And cardiological symptoms, it is discomfort in the region of the heart, palpitation, and cardiac arrhythmias. For diagnostic of gastroesophageal reflux diseases, very important gold standard of diagnostic, it is 24 hours esophageal pH monitoring. But very important, endoscopy. Endoscopy involves esophagogastroduodenoscopy, and pathology of esophagus may be 4 degree. First degree, it is focal erythema and inflammation and loose mucosa of the abdominal esophagus, abdominal part of esophagus. Second degree, it is total inflammation erythema, abdominal esophagus with fibrosis, single superficial erosion. Third degree, inflammation of the abdominal and thoracic esophagus part, and multiple erosions. Fourth degree, ulcer and or stenosis of esophagus, Barrett syndrome, and maybe malignant of the esophagus. Esophageal biopsy, too very important because it is help take morphological disorders of the esophageal mucosa. And stages or symptoms of morphological disorders, it is speak about severe, mild, moderate, or severe variants gastroesophageal reflux diseases. And 24-hour esophageal pH monitoring, it is gold standard of diagnostic gastroesophageal reflux diseases. Because very important, not only diagnostic esophageal reflux during endoscopy, it's very important monitor during 24 hours how many times present gastroesophageal reflux per day and what level of this regurgitation acid stomach juice. Principle of treatment, gastroesophageal reflux diseases. It is, first of all, diet, postural therapy, and pharmacotherapy. Diet therapy, very important to any gastroenterology diseases. Gastritis, gastroesophageal reflux diseases, ulcer, or bile disturbances, maybe inflammatory bowel diseases. It is very important diet therapy. In this diagnosis, gastroesophageal reflux diseases, very important eat of patient organization diets 5-6 times per day, but small portion any time. Very important quality of food. Food must be soft, non-irritating, non-spicy. Not very hot and not very cold. So for any verbs, very hot tea or very cold ice cream, it is food for maybe provocate gastroesophageal reflux diseases exacerbation. Postural therapy, it is position therapy. Patient must be last time eat before 2-3 hours before bedtime, before patient baby go to sleep. And very important organization, high position during sleep. And it is maybe 15 centimeters upper all bed. Bed stand in special boxes, more than 15 centimeters under the door. And clothes do not squeeze the chest and abdomen. And third principle of therapy, it is pharmacotherapy. First of all, must be normalized acidity of gastric juice. And help in this pathological process, proton pump inhibitors. In pediatrics, maybe omeprazole in adolescents and teenager. If the child younger than 10 years, it may be rabeprazole or esomeprazole. Rabeprazole dose of these drugs 20 milligram per day, esomeprazole 20 milligram twice time per day. And proton pump inhibitor recommended long time, minimum 2 weeks, maybe till 4 weeks. Because gastroesophageal reflux diseases, it is diseases whose development some months maybe, or maybe years, and full recovery, mucose of mucose of esophageal mucose disorders, it is 2 times, must be 2 or 4 weeks. Prokinetics and correction of esophageal motility, it is maybe domperidone, very popular pharmacological supplements, domperidone. We recommended these drugs baby younger than 3 years, maybe older than 6 months, if the patient recurrent vomiting, if the baby with regurgitation, physiological or gastroesophageal reflux without diseases, domperidone we recommended it in pediatrics. Dose of domperidone 0.25, it is younger baby, more than 0.5 milligram per kg. It is 3-4 times per day during 3-4 weeks. Domperidone longer than proton pump inhibitors. And maybe trimibutine. Trimibutine, it is correction of esophageal motility, long time, till 12 weeks maybe. Antacid drugs, aluminium phosphate, 1 package, 16 gram, 3-4 times per day during 2 weeks. And combinate antacids, maybe, for example, Givascon, it is 5 milligram or 5 gram, 3-4 times per day during 3 weeks. Chronic gastritis and gastroduodenitis. Chronic gastritis or gastroduodenitis, it is chronic, recurrent, included to progressing inflammatory dystrophical damage of mucosa of stomach and or duodenum. Maybe only gastritis, but very often in patient may be mixed gastritis and gastroduodenitis. Etiology of chronic gastritis may be divided to three groups of factors. Maybe endogenous etiologies factors. It is primary autoimmune diseases. For example, autoimmune diseases, inflammatory bowel diseases, maybe rheumatoid arthritis, idiopathic arthritis, dermatomyositis, lupus erythematosus, or any autoimmune diseases, maybe complications with gastritis, chronic gastritis, and name this gastritis autoimmune or A gastritis. B gastritis, it is exogenous etiologies. It is very popular, very good knowledge this infected Helicobacter pylori. Helicobacter pylori, more than 90% of patients with gastritis, gastroduodenitis, and also peptic ulcer diseases provocate Helicobacter pylori. And maybe a combination exogenous and endogenous content with irritation of stomach by drugs or expressed duodenogastral reflux. It is maybe chemical gastritis or reactive gastritis, C gastritis. Pathogenesis is gastritis or gastroduodenitis. It is two name scales of Shea. Shea is a gastroenterologist doctor, professor, who recommended this hypothesis about pathogenesis of gastritis, gastroduodenitis, and now in all pediatrics and gastroenterology school in different country recommended work with these scales of Shea. It is two group factors, factors of protection and factors of aggression. Factors of protection in stomach and duodenum, it is mucous barrier. Mucous barrier, it is bicarbonates, mucin, sialic acids, intraduodenal acid break, regeneration of the mucous because chloroacidity it is aggressive factors, and chloroacidity synthesis in health human and patient with gastritis or ulcer, peptic ulcer, and our regeneration peculiarities, features of the mucosa of the stomach and duodenum, it is very good regeneration. If the in patient these factors decrease, it is maybe provocate development gastritis or gastroduodenitis. And very important, good blood supply to the stomach and duodenum. It is factors, all these factors, it is factors, natural factors. It is factors who present anatomical and physiological features in our gastrointestinal tract, humans' gastrointestinal tract. And speak about factors of aggression. Aggression, it is first of all hypersecretion of hydrochloric acid or chloride acid into the stomach. Very aggressive impact the lysolecithin and bile acids. It is same to pathogenesis of gastroesophageal reflux diseases. Lysolecithin and bile acids, it is if the present duodenogastral gastroesophageal reflux, it is very, very aggressive. Increased tone of the nervus vagus or vagotonia. In last centuries, in 20th centuries, theoretic about nervus vagus reasons of the peptic ulcer and gastritis, gastroduodenitis was very popular, and sometimes was surgeries vagotomy, but results of these surgeries was not very high percent positive recovery. And now we understand nervus vagus play important role, but it is not one of the reasons factors, and not one factors of the in development gastritis or gastroduodenitis. But if the patient, if the child emotionally ill, emotion instable, if the child maybe with nervous very emotion, maybe red dermographism, sweating, peripheric part of the extremities. It is one of the predisposition factors to development pathology of gastrointestinal tract. Next, it is infection factors, very high percent. I repeat, 90 and more, 95% of gastritis and ulcer, it is Helicobacter pylori positive patient. What may be a child infected of this bacteria? It is maybe hygiene incorrect in family. For example, it is maybe common table, common spoon, common maybe glasses, common cup of family. If the in family ill, one of the person, adult person, parents, maybe grandfather, maybe mother, maybe father, if the adult person of the family ill of Helicobacter pylori and cooking and testing children's food, maybe first feed-ups, maybe cereals, maybe children puree, maybe children soup. And if the same spoon mother testing food for baby and beginning feeding baby this spoon, it is Helicobacter pylori, maybe infected children gastrointestinal tract. Second, it is maybe kiss of baby in lips. Not recommended kiss baby in face, in lips. Not only Helicobacter pylori, it is maybe infected and respiratory viral infection or infected bacterial, for example, beta hemolytic streptococcal group A. It is too very dangerous infected maybe for child. Envelopes infection factors play important role in the factors of aggression to development gastritis or gastroduodenitis. Some medication too play important role in the aggressive factors, and it is maybe not only medication, it is maybe gaseous drink, it is maybe fair fatty food. In adult, it is very important smoke and alcohol, maybe beer, maybe more, any alcohol drink. And adolescents and adult play two additional negative aggression factors, aggressive factors in pathogenesis of gastritis and gastroduodenitis. Poor blood supply to the stomach and duodenum. In this slide, you look two positions. One, good blood supply. Second, poor blood supply to stomach and duodenum. What it is? It is maybe discussed next. If the patient regular feeding 5-6 times per day, it is good blood supply in the gastrointestinal tract, in stomach and duodenum. If the irregular food, if the child or teenager, adolescent or adult, if the human feeding not regular, it is very severe hungry and the patient eat large portion, and it is not normal peristaltic, not normal work stomach and duodenum. And resume of this slide. In low on the slide, I write factors of protection low, factors of aggression high, and it is provocate gastritis and gastroduodenitis. This scheme, same and scales of Shea maybe help you to understand pathogenesis. Peptic ulcer 2. Classification of chronic gastritis or gastroduodenitis. One international classification of this diagnosis absent, but work classification next. First of all, it is maybe origin primary chronic gastritis or gastroduodenitis. It is gastroduodenitis for exogenous factors, Helicobacter pylori, or chemical C gastritis, B gastritis. Secondary gastritis, it is gastritis who provocate endogenous factors. It is all autoimmune diseases, connective tissue diseases, or diseases with abnormal digest food. For example, it is inflammatory bowel diseases, Crohn diseases, or ulcerative colitis. It is maybe diseases with hereditary insufficiency enzymes. It is maybe celiac diseases, maybe lactose insufficiency, galactose insufficiency, systemic diseases. It is maybe diseases with connective tissue, for example, rheumatoid arthritis, idiopathic arthritis, sclerodermia or dermatomyositis, rheumatologies, and any systemic diseases. Granulomatosis 2 in this primary diagnosis may be secondary development chronic gastritis. Why secondary gastritis very serious? One side, it is autoimmune etiology, endogenous. A second, it is this serious diagnosis, inflammatory bowel or systemic diseases or granulomatosis. It is this diagnosis treat long time immune suppressed therapy. Immune suppressed therapy, it is maybe 5-aminosalicylic acid drugs, sulfasalazine, mesalamine, mesalazine, or corticosteroid therapy, maybe long time, or pulse therapy, a large dose of systemic corticosteroid. It is maybe cytostatic chemotherapy, and it is second provocate factors, endogenous plus endogenous chemical and autoimmune gastritis provocate. Second position in classification, it is localization pathological process. Gastritis may be only antral part, fundal part, or pan-gastritis. Then more localization, more generalized pathological process, more severe status of the patient, and more severe clinical symptoms of gastritis or duodenitis. In duodenum may be focal only bulbitis or panduodenitis, and mix gastra and duodenum, gastroduodenitis, localization pathological process in both organs, gastric and duodenum. During endoscopic esophagogastroduodenoscopy, you maybe look not only localization, not only focal square of the pathological process, and in endoscopic maybe different variants. It is maybe erythematous, superficial exudative process, maybe development erosive, hemorrhagic, atrophic, and mixed. What mix? It is maybe in antral part erosive, in fundal part maybe hemorrhagic, or in duodenum bulbitis maybe erosive or erythematous or exudative process. It is named mix. Morphological characteristic. Morphologic characteristic, must be take biopsy. But in pediatrics, biopsy during endoscopic method, gastroesophageal esophageal gastroduodenoscopy. Morphologic may be difficult because not all parents may be correct take biopsy material. Now, if the present these methods, you may be diagnostic. It is superficial or diffuse process in the mucosa. Secretion, very important to management of the treatment of patient. It is must be diagnostic secretion of the stomach. It is maybe acid secretion is not disturbed. It may be increased secretion chloride acid. It may be decreased chloride acid. In these three variants, secretion without disorders increased or decreased, very high percent patient in pediatrics, in childhood, it is increased. But maybe secretion is acid secretion is not disturbed, or maybe very serious situation if the present decreased secretion. It is speak about serious and very long time chronic process, and maybe atrophic or malignant mucosa in the stomach or duodenum. Period, any chronic diseases present some periods. In chronic gastritis and gastroduodenitis, different next periods. It is maybe period of exacerbation, period incomplete remission or subremission, period complete clinical remission, clinical endoscopic remission, and clinic endoscopic morphologic remission. Characteristic any periods. In exacerbation present complaints may be all three syndrome, pain syndrome, dyspeptic syndrome, intoxication syndrome. In exacerbation may be picture in the endoscopic picture character into inflammation process in the stomach. PH-metry speak about hyper or hypo, decrease or increase secretion. It is period of exacerbation. Period in complete remission. In this period, decrease subjective complaints, pain decrease or absent pain, appetite increase, dyspeptic syndrome decrease. But if you palpated patient, for example, Mendel signs or symptoms of Mendel, or maybe deep palpated epigastrium region, patients speak about pain syndrome continuous. And on endoscopic method, during endoscopic method, present disorders of the mucosa. Complete clinical remission. It is absent subjective and absent during palpation, palpation or symptoms. Deep palpated abdomen. It is normal laboratory test. Clinical endoscopic remission. It is very good, but in biopsy material may be morphologic not full success. And very good variants of periods in the patient with chronic gastritis or gastroduodenitis. It is clinical endoscopic morphologic remission. It is very good for patient with chronic gastritis. What clinical syndromes of chronic gastritis and gastroduodenitis may be? Any gastrointestinal tract diseases present three syndrome: painful, dyspeptic, and intoxication syndrome. Pain in gastritis, pain syndrome characterized next. In gastritis with preserved or increased acidity, there are intensive pain in epigastrium or left hypochondrium, round umbilical region, often on empty stomach. What patient localizate pain around umbilical region? What patient speak about epigastrium or left hypochondrium? If it is gastritis, it is maybe localized pain in epigastrium. If the present gastritis and gastroduodenitis, maybe hypochondrium, left hypochondrium, or children, younger baby, maybe complains to round umbilical region pain. What time after meal? There may occur after meal in gastritis with hypoacidity. The pain others are of small intensity without accurate localization, more often after meal. Hyperacid product, it is early pain after meal. Hypoacidity, it is maybe later pain, more than 1 hour. In gastroduodenitis, painful syndrome is marked. The pains are intensive, localized in epigastrium or hypochondrium, on empty stomach or 1/2 or 2 hours after meal, and sometimes maybe in gastroduodenitis more than 3 years, maybe seasonal spring or autumn exacerbation. In first 2-3 years, seasonal may be absent and maybe in any time, maybe in morning, maybe in summer, maybe in winter. After 3 years chronic process, it is maybe seasonal time. Dyspeptic syndrome. Gastritis with preserved secretion or hypersecretion, there are heartburn. Heartburn, same 2 symptoms of gastroesophageal reflux diseases. Heartburn, so belching, thirst, constipation, and appetite is usually preserved. In gastritis with hyposecretion, appetite is decreased, there is feeling of weight and discomfort in epigastrium and left hypochondrium, gaseous, meteoric belching, tendency to diarrhea. During gastroduodenitis, dyspeptic syndrome is similar to that one in gastritis with hyperacidity, but it is more marked. Intoxication syndrome. Clinic of intoxication syndrome during gastritis may be not specific. It is very popular symptoms, intoxication syndrome, to many gastrointestinal tract diseases. It is maybe weakness, flaccidity, irritability, bad sleep, frequent headache, paleness, blue tint of skin under eyes, and dryness of skin. Sometimes maybe dryness of lips and tongue. Involvement of other digestive organs, liver, pancreas, and intestine, interpathological process. In the phase of remission, the signs of the disease may be absent, but low blue tint of skin under the eyes and dryness of skin, it is maybe continuous in a long time of patient with gastritis or gastroduodenitis. Algorithm of diagnostic of chronic gastroduodenitis or chronic gastritis. First of all, it is classic clinical examination. Analysis of anamnesis data, very important, speak what initiated of gastritis symptoms, pain syndrome, dyspeptic syndrome, what provocate factors was. It may be stress, maybe any viral infected, maybe bacterial infected, maybe respiratory diseases for children, infected diseases, measles, chickenpox, or any influenza, parainfluenza. Now very actual new COVID infection, because in children disorders of gastrointestinal tract more often than adult patient with COVID infection. Any interesting questions in anamnesis data? It is family anamnesis. Hereditary predisposition to gastrointestinal tract diseases. It is present in this, and we must ask not only parents and maybe grandma, grandfather, and any person in this family in gastrointestinal tract diseases, maybe ulcer, maybe biliary system problem, maybe pancreatitis, or any diseases gastrointestinal tract. In anamnesis, very important what provocate. It is provocate factors, maybe non-infected provocate factors, for example, food, fatty food, or stress, emotion stress, maybe exam, maybe any provocate factors, stress factors. Physical examination. In physical examination, beginning from superficial palpated of abdomen. During superficial palpated, if it is exacerbation, period of exacerbation, maybe pain in epigastrium, in umbilical around umbilical cord, maybe pain in the right hypochondrium or all epigastrium region. Superficial palpate may be painful. If the pain intensive, child may be constrictive musculus rectus abdominis, and it is doctor must be controlled during manual skills. After physical examination, after superficial palpated, deep palpated, and Mendel signs. Mendel signs, it is symptoms, movements same to percussion in epigastrium region. If the patient complains to severe pain during this percussion movement in epigastrium region, it is symptom of Mendel positive. Endoscopic recommended instrumental investigation. First of all, it is endoscopic method. Endoscopic esophagogastroduodenoscopy recommended. Now it is recommended all patients with specific complaints, pain syndrome and dyspeptic syndrome, who character to gastroesophageal reflux diseases or chronic gastritis, gastroduodenitis. During endoscopy, maybe take biopsy material, maybe without biopsy. Ultrasound examination of abdominal organs of abdominal cavity. It is too important for identified. It is only gastroduodenal diseases or present parallel to chronic gastroduodenitis or gastritis, maybe secondary diseases of gastrointestinal tract, for example, reactive pancreatitis, maybe biliary system disturbances, maybe cholecystitis, and maybe any liver problem or pancreas, liver, and any organs of abdominal cavity. Very important intragastric pachymetry, because in this method help different. It is patient with hyperacid, hypoacid, or normal chloride acid synthesis. X-ray examination. In 21st century, it's very popular endoscopic and ultrasound of ultrasound method. X-ray examination stand on second position, on last position. It is maybe only patient if necessary according to indications. It is if the patient may be localization of the pathological process, if not diagnostic in endoscopy. In endoscopy, Results of endoscopy may be next. Usually reveals focal or diffuse hyperemia of mucosa, edema of mucosa, hypertrophy of folds, follicular hyperplasia, plain or elevated erosion may be revealed. These changes are usually associated with Helicobacter pylori infection. Histological investigation may be on stomach and duodenum mucosa by means of aspiration biopsy is obligatory diagnostic method for chronic gastroduodenitis and gastritis. It allows to estimate the degree of inflammatory, dystrophic, or dysregenerative process in the stomach and duodenum. Evaluation of the secretory function of the stomach. Very popular, gold standard, it is intragastral pH measurement. Maybe rheogastrography, pepsinogen of plasma is normally at the level of 70 till 100 millimole per higher. Excretion of urapepsinogen is normally 0.3 till 0.8 milligram. Proteolytic activity of urapepsinogen is 0.02 till 0.07 units. Motor function of the stomach and the duodenum is investigated by means of electrogastroduodenoscopy. X-ray examination with barium and ultrasonic examination after filling of the stomach with water. This can reveal sphincter disturbances, refluxes, etc. Very important diagnostic Helicobacter pylori infection. Next methods may be to diagnostic Helicobacter pylori infection. First of all, it is morphological method. During morphological method, it is method take material, biopsy material in endoscopic, and it is gold standard of diagnostic. If the diagnostic really diagnostic bacteria Helicobacter pylori, it is very high percent correct investigation. Bacteriological method, it is method culture in the special laboratory, but it is not absent in any hospital. Very popular now, it is polymerase chain reaction, PCR reaction, is examination of Helicobacter pylori in stomach for DNA. It is high percent positive results to PCR to the Helicobacter pylori. Low percent correct investigation, it is urease test and stool test. But this not painful method, urease and stool test, and it is maybe for control positive or negative therapy of the Helicobacter pylori eradication. Urease test respiratory method, it is evaluation of increased urea metabolites under the influence of Helicobacter urease after prior intake of urea. And stool test, it is maybe identified Helicobacter pylori in the stool, but it is not higher percent correct answer. Treatment of gastritis, I speak together with peptic ulcer treatment because it is a scheme of treat same. Peptic ulcer of the stomach and duodenum. Peptic ulcer is a polyetiological, genetically and pathogenetically heterogeneous diseases. Ulcer are deep lesions that breach the integrity of the epithelium and penetrate through the muscularis mucosa, whereas erosions are superficial and stop short of the muscularis propria, caused by breaking between balance of local protective and aggressive factors. We next time speak about share, scale of share. Also, gastric and duodenal ulcer occur infrequently in children. The prescribed prevalence is unknown. Gastritis and ulcer of the duodenum or stomach can be classified either as primary or secondary. This classification is arbitrary and predates the knowledge of the association between Helicobacter pylori infection and duodenal and gastric ulcers. The majority of children with active gastritis and ulcer in stomach or duodenum will have an associated systemic condition, such as overwhelming sepsis, severe head or body trauma or burns, or be on medications such as non-steroidal anti-inflammatory drugs. Epidemiology of peptic ulcer next. Peptic ulcer disease in children is relatively uncommon, with an estimated index of 1.6 plus minus 0.1 children per 1,000 children. Gastric ulcer, it is 13% from all patients with peptic ulcer diseases. 13% it is gastric, 81% duodenum ulcer, and combination gastric ulcer and duodenum, it is 6% of the patient with peptic ulcer diseases. Peptic ulcers are found most frequently in children between the age of 12 till 18 years, and boys being affected 2-3 times as often as girls. Why 12 till 18 years? Maybe children in this time beginning smoking, beginning drink alcohol, maybe not regular feeding, maybe more stress factors in period of adolescence, pubertal period than children younger. If the baby 5, 6, 7 years, parents more control diets, child eat in primary school, in kindergarten, regular feeding 5-6 times per day, and teenager patient in adolescence period may be not regular feeding, and maybe any stress factors, emotion stress, physical exercise, and smoking too play important role in peptic ulcer in adult and adolescence and adult. Pathogenesis. The pathogenesis of peptic ulcer disease is incompletely understood. Ulceration occurs when aggressive factors, it is gastric acid, digestive enzymes, Helicobacter pylori bacterial products, overwhelm the natural barriers that protect the gastroduodenal lining. Bicarbonate mucous barrier, gastric epithelial cells, mucosal blood flow, prostaglandins. It is same scheme share, scales of share. Patients with duodenal ulceration may have increased acid secretion, whereas patients with gastric ulcer may have reduced acid output. Drugs such as non-steroidal anti-inflammatory agents inhibit protective prostaglandin synthesis and reduce the mucosal production of bicarbonate. Helicobacter pylori colonization leads to a blunted response of duodenal bicarbonate secretion in response to intraluminal acidification in adults. The ability of mucin, mucose glycoprotein, to normally polymerize may be altered altered in patients with duodenal ulcer. Patients who develop ulcer may be genetically predisposed. Increased levels of pepsinogen are seen in children with duodenal ulcer and their parents' peptic ulcer disease may be in either parent of an affected child. Classification of the ulcer. This classification too, not international society, it is a work classification in different textbook recommended this. One of characteristic of ulcer, peptic ulcer diseases, it is localization. Ulcer may be localized in stomach, ulcer of the stomach, maybe ulcer of the duodenum, and ulcer both organs, ulcer of the stomach and duodenum. Chronic diseases present some phase of process. It is maybe period of exacerbation or phase of exacerbation, maybe incomplete remission or sub-remission if the present endoscopic laboratory test speak about the pathological process, but complaints decrease in this period incomplete remission, and the period or phase of clinical remission, it is phase where absent clinic and instrumental investigation method pH-metry or endoscopic morphological method speak about full recovery, full remission in this patient. Classification by clinical endoscopic stages. It is maybe stage of active ulcer, the beginning of the epithelialization of ulcer, ulcer healing, clinical and endoscopic remission. Next parameters of classification, it is maybe ulcer associated with Helicobacter pylori, maybe peptic ulcer diseases, for example, ulcer of the duodenum, period in the clinical and endoscopic maybe remission, and Helicobacter pylori negative, or maybe more serious example of diagnosis, it is maybe ulcer of the stomach, period of exacerbation, clinic endoscopic stage, the beginning of epithelialization of ulcer, Helicobacter pylori positive patients, uncomplicated. It is more simple, more positive prognosis of patient with ulcer or diseases. Clinical signs of peptic ulcer disease. 3 syndrome 2 present in this diagnosis. First of all, it is painful syndrome. Pains are intensive, paroxysmal, which occur 1.5 till 2 hours after meal, more often at night and on empty stomach. It is very character to patient with ulcer. And very important different painful syndrome in gastritis, 2 maybe in epigastrium, maybe after meal, but intensive pain, characteristic by intensive between ulcer and gastritis different. More intensive pain in ulcer. And if the patient beginning stand up on night, nocturic pain in abdomen, in epigastrium, it is very serious signal about more severe erosion, gastritis, maybe erosion and transform to peptic ulcer diseases. Food intake relieves pain. The pain is localized in epigastrium, umbilicus, right subcostal area, sometimes irradiates to waist or has spread character. It is absent in the gastritis. The pain is frequently connected with intake of coarse and plain food. Seasonal exacerbation of painful syndrome, spring and autumn, is remarked. It is very character to the ulcer diseases, more character than gastritis or gastroduodenitis. There is tenderness on palpation in a piloroduodenal area, muscular defense, and hyperesthesia of skin in tender zone. It is Zahareва-Get zone, and positive sign of Mendel. I repeat next time, what is it? Some positive sign of Mendel. After palpation of abdomen, superficial palpated, you may be movements same to percussion, a zone where you palpate percussion movements. It is epigastrium. Tenderness and very severe pain during percussion movements, name positive sign of Mendel. And Mendel signs may be positive not only in exacerbation, it is maybe partial remission, sub-remission to the sign of Mendel may be positive. Second group of symptoms, it is syndrome of dyspeptic syndrome. More severe vomiting, nausea, heartburn. Vomiting frequently causes relief, removing pain. It is very character to ulcer. More intensive vomiting, and vomiting frequently cause relief. So bitter food, gaseous irritation. It is subjective discomfort, and it is very uncomfortable for patient. In case of pyloric stenosis, belching with musty smell is present. Most patients' appetite doesn't change, but some of the patients may have decrease of appetite and low weight during exacerbation. Very important this symptom, decrease pain, decrease of appetite and weight of child decrease. If the pain provoked of meal, after meal, patient may be complains to severe pain, and child may be speak about decreased appetite and low mass. Tanga is quoted tendency to constipation in patient with increased gastric acidity or unstable stool in patient with low gastric acidity is present. Sometimes may be irregular stool. Some days may be diarrhea, some days may be watery stool, and after them maybe 1, 2, 3 days absence to constipation. It is too present in this diagnosis. If we speak about Minigam rhythm of the pain, it is we must speak about Minigam type of the pain. Hungry provocate pain, light food decrease pain. It is very typical for gastritis or for peptic ulcer, and it is very character about these symptoms. Adolescents speak very quickly, doctor. Minigam rhythm of the pain, seasonal night pain, seasonal nocturnal pain, and Minigam rhythm of the pain. It is very character symptoms to the ulcer diseases. And intoxication syndrome during gastritis and ulcer diseases and stomach and duodenum. It is maybe weakness, flaccidity, bad sleep, frequent headache, irritability, tearfulness, increased disposition to perspiration, blue shadow under the eyes, possible emotion, and accompanied damage of other organs. It is maybe liver, pancreas, maybe gallbladder. Instrumental and laboratory findings in a patient with ulcer diseases. It is first of all endoscopic. Endoscopic investigation, fibrogastroduodenoscopy, reveals ulcer lesion. X-ray signs of ulcer. It is maybe direct sign if two with very contrast ingredients. Direct signs niche with inflammatory elevation, raw, convergence of folds, cytatical deformation of the stomach, the duodenal bulb. Indirect signs, it is hypersecretion on empty stomach, strenous segmentation. Treatment. Very serious treatment in ulcer of the ulcer diseases. It is in exhibition must be treatment at hospital. Any age of child, ulcer diseases, peptic ulcer, must be treatment at hospital, because maybe complications, maybe bleeding, maybe stenosis, maybe penetration or perforation of ulcer, and we beginning of treatment in hospital. The objectives of treatment are to relieve ulcer pain, to hasten healing, to prevent recurrences and complication. Treatment should be offered to patients with Helicobacter pylori who have ulcer, both duodenal and gastric, and have a history of ulcer, and gastritis and gastroduodenitis. Several treatment regimens are available to treat Helicobacter pylori infection. It is, if the peptic ulcer, gastritis and gastroduodenitis more than 95%, it is Helicobacter pylori infection. Recommended begin treatment. All three always diagnosed. Gastritis, gastroduodenitis, peptic ulcer, beginning treatment of eradication for Helicobacter pylori. Beginning history of eradication therapy, beginning from 7 days. Now Helicobacter pylori more resistance, infected more aggressive, and now recommended eradication therapy more than 10 days, 10 or 14 days. Initial in last centuries, we beginning treatment Helicobacter pylori 7 days. Proton pump inhibitors. Proton pump inhibitors stand in the modern recommendation, clinical recommendation of the International Gastroenterologist Forum or Russia Federation Gastroenterologist specialties. Recommended beginning proton pump inhibitors, rabeprazole 20 mg per day, esomeprazole 1-2 mg per kg day during 10-14 days. Amoxicillin, it is 3-component scheme. Omeprazole, amoxicillin 50 mg per kg, and clarithromycin 20 mg per kg day. Second variants may be inhibitor proton pompa, clarithromycin 20 mg, and metronidazole 20 mg per kg. It is second scheme of eradication Helicobacter pylori. Next combination, it is maybe inhibitor proton pump plus amoxicillin or clarithromycin if the patient present allergic reaction to amoxicillin, and nifuratel in dose 30 mg per kg day. Maybe combination proton pump inhibitor plus amoxicillin plus zozamicin. In first line therapy, 3-component first line therapy, absent bismuth. proton pump, 2 antibiotics, or proton pump antibiotics and metronidazole, or proton pump antibiotics and nifuratel, or proton pump amoxicillin and zolzamicin. If the first scheme, 3-component scheme, not effective, maybe scheme second line therapy, 5 days proton pump inhibitor, bismuth subcitrat, 8 mg per kg day, and antibiotic amoxicillin. After these 5 days, proton pump, bismuth, and amoxicillin, next 5 days, proton pump and bismuth continuous, but amoxicillin changed to zolzamicin, and scheme to 10 days. Any therapy, any drugs or pharmacology drugs who put in complex therapy in ulcer and gastritis duodenitis. It must be probiotics and prebiotics, maybe combination pharmacology supplements, symbiotics. It is drugs with combination pro and prebiotics characteristic. It must be bifidum bacteria, lactobacteria, and it is prebiotics, maybe monocarbohydrates, monosaccharides. Prokinetics, it is domperidone. If the present very good work this combination, omeprazole, antibiotics, and prokinetics, domperidone, if the inpatient present gastroesophageal or duodenogastral and gastroesophageal reflux. If the present abnormal regurgitation in gastrointestinal tract, domperidone must be long time, maybe 3 weeks, maybe 4 weeks, and maybe continuous 12 weeks. Trimetabutin to very good recovery of the mucus of the gastrointestinal tract. Maybe spasmolytics. If the severe pain, spasmolytics, drotavirin, noshpa, mebivirin, papavirin, to good work in short period, maybe 5 days, maybe 7 days, till pain syndrome decrease. Any antacid drugs who may be neutralizing gastric acid. The most common side effect is diarrhea secondary to the magnesium contained in many antacids. If a patient has renal insufficiency, the magnesium levels should be monitored. Aluminium hydroxide antacid can result in constipation, phosphate depletion, osteomalacia, and osteoporosis. And these drugs, if they present omeprazole, these supplements may be not recommended. But if the severe pain and antacid only omeprazole partial effect, maybe normal antacid normal procedure is to alternate magnesium hydroxine with aluminium hydroxine antacids to minimize diarrhea and to prevent phosphate depletion. Calcium containing antacid can result in acid rebound and future release of gastrin. Sodium containing antacid can result in salt and water retention. H2 antagonist currently used is if patient has intolerance to proton pump inhibitor. Now H2 antagonist stand on last position. It is recommended only patient with intolerance to proton pump inhibitors. H2 antagonists act to block the histamine receptor responsible for acid secretion. Cimetidine is given 4 times a day in a dose of 24 mg kg day for 6-12 weeks. Side effects of cimetidine include gynecomastia is less than 5%, oxygen rush, or behavioral abnormality, as well as reports of decreases in sperm counts and thrombocytopenia. Rebound hypersecretion of hydrochloric acid has been described after discontinuation of the drug. A longer-acting H2 receptor blocker, ranitidine, is given twice a day in dose of 4-8 mg per kg day. The side effects are similar to those of cimetidine. Direct mucosal coating. Sucralfate, a polyaluminum hydroxine sol, forms polyvalent bonds to necrotic tissue proteins, preventing contact with pepsin and acid. The drug is non-absorbed and so has few, if any, side effects. The dose is 1 gram per 1.73 meter square. It is standard meter square in the human. And maybe surgical intervention is very uncommon and occurs when uncontrollable hemorrhage or perforation occurs. The usually surgical procedure includes ligation of the bleeding artery, oversewing of the ulcer, vagotomy, or pyloroplastic. And complications of the ulcer. Next may be complications of the ulcer: acute bleeding, mild, moderate, or severe, penetration in pancreas, liver, lesser omentum, perforation, acute in anamnesis, post-hemorrhagic anemia, may be development stenosis, compensated, subcompensated, or decompensated stenosis, different pyloric or cardiac sphincter, or reflux esophagitis development, and maybe secondary hemorrhagia in complications of the ulcer. I finish lectures in this fourth course.